Welcome to an introduction to high-frequency jet ventilation. This presentation is intended for bedside nursing staff in order to gain insight into what high-frequency jet ventilation is, how it works, and why it is different from conventional mechanical ventilation. It will outline the features of the LifePulse, also known as the jet, and provide you with information on caring for your patients. This presentation will discuss the basic stages of lung growth and development and demonstrate why mechanical ventilation in neonates can be difficult. Differences between conventional ventilation and high-frequency jet ventilation will be identified. Indications for use and why it's used in tandem with a conventional ventilator will be outlined. Important aspects of the jet as related to your role as a bedside nurse will be discussed. Helpful techniques on how to care for patients will also be covered. Babies' fragile lungs go through delicate structural changes over 40 weeks gestation. Although the development of primitive air sacs occurs around 17 weeks, prior to 22 weeks it is nearly impossible to save babies due to lack of alveolar development and capillary structure. Even though the development of alveolar ducts and pulmonary capillary bed growth increase viability at 22 weeks, these babies continue to have high morbidity and mortality rates. At 24 weeks, lung development accelerates. Marked changes in both the number of alveoli present and the surface area of the pulmonary capillary bed increases the ability to ventilate. Although surfactant production begins, it is inadequate until closer to 28 weeks. From 28 to 36 weeks, alveolar growth, capillary perfusion, and surfactant production increase dramatically. The lungs are considered fully functional by 36 weeks gestation. Mechanical ventilation prior to 36 weeks holds unique challenges based on the gestational age and the stage of development. Conventional ventilators deliver relatively large tidal volumes with long inspiratory times. The delivered volume reaches the distal airways and developing alveoli, which can damage the delicate structures. Distal airways, rather than the alveoli, are the most compliant part of the respiratory tract. Underdeveloped airways lack structural strength. Large conventional breaths cause them to stretch and inflate more easily than compared to surfactant-deficient alveoli. This stretch and strain on the distal airways leads to a rupture, causing an air leak. The jet offers important clinical advantages over other forms of ventilation. Small tidal volumes combined with extremely short inspiratory times create the lowest possible peak and mean alveolar pressures. Gentle breaths from the jet allow air leaks to heal. Passive exhalation is possible by exhaled gas following the path of least resistance, swirling out and around the incoming gas. Less mean airway pressure is required to maintain airway inflation during exhalation. Adjusting settings on the jet allows for a very long expiratory time, which is beneficial for avoiding gas trapping. The LifePulse high-frequency ventilator is indicated for use in ventilating critically ill infants with pulmonary interstitial emphysema and ventilating critically ill infants with respiratory distress syndrome complicated by pulmonary air leaks who are, in the opinion of their physicians, failing on conventional ventilation. With over 30 years of clinical use, clinicians have expanded the jet application to include a variety of challenging pathophysiologies. It is useful in the treatment of non-homogeneous lung disease, situations including, but not limited to, chronic lung disease or congenital diaphragmatic hernia. Swirling passive exhalation aids in clearing excessive secretions found in meconium aspiration syndrome, common pneumonias, and RSV. The use of lower mean airway pressures are ideal for patients with hemodynamic compromise associated with prematurity, congenital heart defects, or PPHN. Due to the jet's unique characteristics, it often works as a rescue device when everything else has failed. Now, rather than waiting for lung damage to occur, many hospitals have implemented the jet as the primary mode of ventilation for first intention lung protective strategy in the management of extremely low birth weight babies. The jet will always be paired with a conventional ventilator. This allows for the separation of oxygenation from ventilation. By creating tiny breaths with set peak inspiratory pressure, the jet is responsible for ventilation or CO2 removal. The conventional ventilator has three important roles and is responsible for oxygenation. It establishes and maintains lung volume through the use of recruitment breaths and PEEP, and also provides flow for patients to be able to spontaneously breathe. The two ventilators are connected together at the endotracheal tube with a specialized LifePort adapter. It allows for the connection of the conventional ventilator circuit, the introduction of the jet breaths through the jet port, and the measurement of each of the breaths through the pressure monitoring line. These adapters come in 5 different sizes based on endotracheal tube diameter. Inline suction can be used with the jet. The remainder of this presentation will focus specifically on how the jet is used in the care of patients. The lower portion of the ventilator with the blue numbers is a humidifier. The center section, labeled Controls with the green numbers, is where the current ventilator settings are displayed. The upper portion with yellow numbers contains both the monitoring and alarm sections. These two sections are where the clinician will see the monitored values and be alerted to changes occurring with the patient. The WhisperJet patient box makes jet breaths and measures pressures at the patient's airway. It is placed into the bed with the patient. To effectively create and measure jet breaths, it must happen as close as possible to the patient. A pinch valve in the patient box rapidly opening and closing quickly creates the puffs of gas and delivers them through the green tubing towards the LifePort endotracheal tube adapter. Here, the velocity speeds up due to the small diameter of the injection port, very similar to adding a nozzle to a garden hose. This is where the gentle breaths are introduced into the patient's lungs. Opposite of the jet port is the clear tubing responsible for monitoring pressures. After the patient box, 12 inches of the circuit remains. Once the jet breaths are made, they need to be quickly and efficiently delivered to the patient. Moving the box further away would dampen the tiny, crisp puffs of jet gas and create inefficiency. For these reasons, the patient box is placed in the bed close to the patient. It can be placed at the head of the bed, the foot of the bed, or wherever it's convenient. Due to the close proximity to the patient, Bunnell has designed the patient box for quiet operation at approximately 45 decibels. The monitoring section displays peak inspiratory pressure, PEEP, delta P, mean airway pressure, and servo. These values are obtained directly in the patient's endotracheal tube, unlike other ventilators that measure 6 feet away. With the measurements close proximity to the patient, values displayed will fluctuate with spontaneous breathing, minute by minute, and with changes in lung compliance and resistance. Because of the high respiratory rate, monitored values are averaged over 10 seconds, so the display will have some delay. Values have alarms associated with them calculated by the device. Monitoring alarms alert the clinician to changes occurring with the patient. Not all alarms are negative. They could indicate the need for weaning. For sustained alarms, contact the respiratory care team. Normal fluctuations due to spontaneous breathing or increased conventional support of less than 5 centimeters of water pressure are not significant, as they are associated with a very small change in tidal volume. Excessive fluctuations, which cause more frequent alarms, need to be evaluated by the respiratory care team. The servo value provides trending information about changes in patient status when no changes have been made to either ventilator. A baseline range is determined after acceptable blood gas results have been achieved and small fluctuations are normal. Servo is much like tidal volume seen on a conventional ventilator. A decrease from the baseline value or a low servo alarm may indicate the need for suctioning, poor tracheal tube position, or decreased compliance. Less flow is being used to maintain the set jet peak inspiratory pressure, therefore less tidal volume is being delivered. A patient assessment should be made to determine the cause. If tube position is adequate and suctioning has been completed without a return to baseline, contact the respiratory care team for further evaluation. An increase from baseline value or a high servo alarm may be related to a leak around the endotracheal tube or improved compliance. More flow is being used to maintain the set jet peak inspiratory pressure, therefore more tidal volume is being delivered. Often a cause may be an endotracheal tube leak that happens after repositioning of patients. If a change in endotracheal tube leak is not the cause, contact the respiratory care team for further evaluation. For continuous alarms related to either servo or mean airway pressure, contact the respiratory care team for further evaluation, adjustments, and troubleshooting. The ready light is located in the alarms panel just above the upper and lower servo limit buttons. Once the jet is activated, prior to the ready light being illuminated, the ventilator is in the non-ready condition. During this learning phase, it is in the process of calculating alarms and generally takes 45 to 90 seconds. Anytime the vent is in the non-ready condition, for any reason, it's important to remain hands-off with the patient. Once a steady environment is established, calculated alarms above and below servo and mean airway pressure are set and active and the ready light turns on. This is known as the ready condition. During operation, the indicator will be on 99% of the time. Pressing standby to pause jet ventilation or pressing enter to make adjustments to ventilator settings will place the ventilator back into the non-ready condition. Make sure the ready light is on prior to performing any patient care such as bath, weights, diaper changing, or repositioning. The jet's alarm system alerts the operator both audibly and visually. Located on the top of the vent is the alarm priority lamp. Specific audible alarms were designed to be consistent with all common ventilators and alert for disconnects, pressure changes, and machine errors. Low priority alarms present with one beep every 18 seconds and a solid yellow light. These alarms are minor in nature and can be checked the next time the RT comes to the bedside. Medium priority alarms exhibit with 3 long beeps every 5 seconds and a flashing yellow light. If these alarms continue repeatedly, it might require a page to the RT to stop by soon. High priority alarms produce 2 bursts of 5 short beeps every 5 seconds and a flashing red light. At this time, call the RT to the bedside immediately. When high priority alarms occur, the first step is to take a quick look at the ready light. If the ready light is on, you've bought yourself some extra time. Look for chest wiggle and verify the patient's vital signs are stable. When the ready light is illuminated, servo value has been locked into place. Flow remains constant and ventilation continues. Press the audio pause button located in the upper right corner and immediately contact the respiratory care team to troubleshoot. However, if the ready light is not illuminated, servo display will not lock into place. The flow and the servo value will drop to 0 and ventilation will stop. Provide manual breaths for the patient via the conventional ventilator or hand bagging system and contact the respiratory care team for immediate assistance in troubleshooting. Ideally, suctioning is a 2-person procedure with RT involvement. Inline suction catheters may be used. To suction, press the standby button to stop jet ventilation and then suction per hospital policy and procedure. In between suction catheter passes, you may need to provide additional support breaths as determined by your hospital practice. When you are finished suctioning, press the enter button to restart jet ventilation. As previously discussed, it is important to wait for the ready light to be illuminated before repositioning and resettling the baby or before leaving the bedside. The jet is plugged into an external blender in order to adjust its FiO2, while the conventional ventilator has an internal blender. The FiO2 must be adjusted on both the jet and the conventional ventilator to ensure the proper FiO2 is delivered. They must match. A quick tip, when you're new at this, use a sticky note that says, "Must change both." Upon assessment, look for adequate bilateral chest wiggle, less pronounced than if you are familiar with oscillation. There are no restrictions on patient positioning. Babies may be rotated from side to side, be placed midline, prone, snuggled, etc. It's appropriate to use gel pads, sheepskins, soft linens, or positioning aids of your choice to create a comfortable environment for them. During HIE body cooling, both the conventional ventilator and jet gas should continue to be heated and humidified to prevent airway damage. It isn't necessary to sedate patients for breathing above the ventilator. As patients get stronger, you may notice larger pressure fluctuations caused by increased respiratory effort. Allowing spontaneous breathing is beneficial to the patient as it allows them to utilize respiratory muscles, preparing them for extubation. Remember, spontaneous breathing is the point of the exercise. The pressure monitoring line facing upward helps prevent moisture from blocking the line, interfering with the displayed monitored airway pressures and causing nuisance alarms. The patient box can be placed on a blanket, a gel pad, or a towel. Make a pillow or a nest to help reduce noise and vibrations. Avoid placing it against the plexiglass wall or the metal ridge of the bed scale. It may be placed in any area of the bed. Unused corners work well. A helpful hint, scoot the baby down in the bed to give yourself some extra room. The JET's flexible circuit not only allows for easy positioning of patients, but it also provides the opportunity for families to participate in kangaroo cares. Relocation to mom and dad's arms will take a team effort of maintaining the airway, patient temperature, vital signs, etc. A quick tip: plan ahead. Work together with your respiratory care team to create a protocol. Bunnell can help with that. Bunnell provides a variety of resources for clinicians. For equipment operation, patient management suggestions, or question about alarms, refer to either the user manual, the quick reference guide, or the alarms and troubleshooting guide. Most importantly for the bedside nurse, there's a parents page available in both English and Spanish format on our website via computer or any mobile device. Additionally, clinicians have access to the Bunnell hotline anytime, 24 hours a day, 7 days a week.